Hello, my name is Dennis Vollmer. I'm a neurosurgeon at the University of Virginia, and in this presentation we will be discussing ossification of the posterior longitudinal ligament, or OPLL. We'll touch on some of the pathophysiology and clinical characteristics, and then review the evaluation and treatment. What is OPLL? OPLL is a relatively uncommon condition which is important to spine surgeons because of its tendency to present with cervical or, in infrequent occasions, thoracic myelopathy. It is described as an enthesopathy, which reflects its pattern of development, and it is noted that it does have variable prevalence based on race or ethnicity, though it has been largely described in all races and ethnic groups. It remains unclear as to etiology, though it does have some association with various genetic markers, and it also is important because it does present the clinician with some challenges that require modification in the usual surgical approaches that one might take in a case of spondylotic myelopathy. The history of OPLL is relatively recent, though it was first reported in 1838 by Charles Key, a surgeon at Guy's Hospital in London, in which he described a case of a patient with paraplegia who had an associated ligamentous ossification. The 20th century had fairly limited reporting in the first half, although two reports, that by Nags in 1925 and Oppenheimer in 1942, probably included cases of OPLL in a more general reporting of ligamentous ossifications in the spine. It really wasn't until 1960 when Tsukamoto reported an autopsy and carefully described OPLL and recognized it as a distinct and somewhat unique pathologic entity. This report apparently sparked quite a bit of interest among the Japanese, and later resulted in a governmental study group with associated funding, which further resulted in extensive studies and publications and raised awareness of the entity both in Japan and in the rest of the world. Partly because of the interest on the part of the Japanese and the publications that came out of Japan, many authors described OPLL in the mid-20th century as the Japanese disease, and it was thought to largely involve that particular group. And in fact, studies coming out of Japan did suggest that prevalence rates were higher among Japanese than many other ethnic groups. However, more recent studies have shown that other East Asian populations have similar, albeit slightly lower rates. For example, as shown here, Chinese reports have shown prevalence of 4%, and South Korea has shown ranges from 0.6 to 4.6% in prevalence. More Western countries seem to have lower rates, although some of the earlier studies have been criticized because of their use of plain films for the diagnosis, and also because of a lower level of awareness which might preclude people from being diagnosed with this condition. A more recent study, though, based in San Francisco, did provide relative comparisons between different racial groups, and as you can see on the slide, Asian Americans had the highest rate of 4.8% compared to Caucasian Americans, who were the lowest at 1.3. Native Americans were the second highest group in terms of prevalence, although of course the numbers were smaller. A number of other things have been noted about OPLL. First of all, not surprisingly, it does seem to increase in incidence with increasing age and is generally not seen clinically before age 50. For the cervical OPLL, which is of course the more common form, the male to female ratio is approximately 2 to 1, although a number of studies have shown relative parity for thoracic OPLL, and in some series the female preponderance has been demonstrated. It's also worth noting that some other comorbidities seem to predispose to the development of OPLL, including such things as type 2 diabetes or adult onset obesity. A brief reminder on the anatomy of the posterior longitudinal ligament. As most of you know, it extends throughout the spine along the dorsal aspect of the vertebral bodies and discs, essentially from the tectorial membrane down to an insertion point on the sacrum. It is approximately 1 to 2 millimeters in thickness under normal circumstances, but in cases of OPLL or even some forms of spondylosis, the ligament may thicken dramatically. Its function is primarily to limit flexion, and it has multiple layers in it. The deeper fibers are spanning one segment, whereas more superficial fibers may extend up and down several segments. The most common pathologic process involving the posterior longitudinal ligament is, in fact, ossification. Ossification seems to occur after some degree of ligament hypertrophy or hyperplasia, though hypertrophy can occur without subsequent ossification, as we'll see in an example in a few slides. This hyperplasia, though, includes proliferation of fibrocartilaginous elements, and it is this fibrocartilage that is associated with endochondral bone islands, and these islands form and then ultimately coalesce to form the bony mass that we typically see. It's noteworthy that other entities such as dish also seem to undergo this process of ligament hypertrophy followed by ossification, and this has caused authors to group these entities together under the title of enthesopathies. Of course, what is an enthesopathy? Is this a useful term? The enthesis is a term describing the insertion point of soft tissue elements such as tendons and ligaments into the bone, and certainly that's an area where the ossification is observed in OPLL. Here is just a partial list of some other disorders that are classified as enthesopathies as well, largely due to the locus of their initial involvement. But the nature of these various pathologies may not be particularly linked. For example, spondyloarthropathies such as ankylosing spondylitis, psoriatic arthritis, and Reiter syndrome may have an autoimmune component. Gout has certain metabolic elements related to urate metabolism, and then there are such things as dish, OPLL, and ossification of the ligamentum flavum that seem to be somewhat distinct as well. Now, histopathologically, OPLL is unique or distinguishable at least from standard cervical spondylotic myelopathy. In the case of OPLL, initial ossification starts within the ligament, and although it's close to its attachment to the vertebral body, it does not start out in contact with the vertebral body, separating it from a normal osteophyte formation. Some authors have posited that ligamentous hypertrophy is the initial stage, and in cases of non-ossified thickened PLL have described this as OPLL in evolution. But as I mentioned before, some cases of ligament hypertrophy are not associated with subsequent ossification. Here is such an example. This is a 60-year-old gentleman who presented with myelopathy, and you can see on the MRI there's a large soft tissue mass ventrally, which does not appear ossified on the CT, though the CT does show some degenerative change anteriorly as well as a congenitally narrow canal. The cross-sectional images show the thickened posterior longitudinal ligament on the MRI and no calcification on the CT of the same vertebral level. This patient was operated on and did show evidence of a thickened PLL without ossification. So, as I said, the specific etiology of OPLL is not known, but a number of associations have been identified, including several genetic factors such as mutation in a number of collagen genes, as well as in the TGF-beta superfamily, both of which relate to connective tissue maintenance and development. Also, single nucleotide polymorphisms have been noted in several genes related to bone metabolism, such as BMPs and BMP receptors. And you can see osteopontin and osteocalcin as well. And then a number of presumably non-genetic associations have also been described. I previously mentioned obesity and diabetes, but also some other endocrine problems such as acromegaly, hyperparathyroidism, and fluorosis and hypophosphatemic rickets have all been associated with higher risk of developing OPLL. Now, brief discussion of the cord histopathology in OPLL. It is not necessarily distinct from cervical spondylotic myelopathy, other than the extent of ventral compression in many of the cases. So spinal cord damage in general probably occurs due to two factors. One is the mechanical compression due to the canal stenosis, and then the dynamic factors related to elongation of the cord and contraction of the cord during flexion extension, as well as some mechanical factors occurring related to translation in dynamic instability. The spinal cord damage in OPLL, much like CSM, primarily involves the gray matter with lesser involvement of white matter elements. Some authors have noted a correlation between the histopathology as well as the shape of the cord seen either at autopsy or in imaging in life. They've divided the cord configuration into two types, the boomerang configuration or the triangular configuration as illustrated in the cartoons to the right. The boomerang form seems to be associated with a greater degree of gray matter loss and better preservation of long tracts, whereas the triangular form seems to have more diffuse involvement of both gray and white matter with more significant corticospinal degeneration. This slide shows some photomicrographs. The upper image showing the kind of gray matter loss typical for OPLL, with loss of volume of anterior horns and depopulation of the neuronal elements associated with some gliosis. The lower slide shows an example of cavitation within the cord with necrosis and thickening of the venular elements, which can contribute to vascular compromise and venous congestion. Clinical manifestations of OPLL are not particularly unique. Patients typically present with signs and symptoms of cervical myelopathy. Most of the patients, as we've said before, are older, and there is some known risk factors, as we previously cited. The most common symptoms for patients presenting with OPLL are myelopathy, radiculopathy, neck pain, and not surprisingly, decreased cervical range of motion. But as I've said before, approximately 30% of patients have OPLL in other than cervical regions, most often thoracic, and this needs to be kept in mind when evaluating patients. Here, for example, is a patient with thoracic OPLL. Although I've said there's tends to be a female preponderance in this area, this was a male patient, and you can see the typical ossified mass of a segmental type OPLL with rather marked distortion of the cervical canal on the CT. It's interesting that the thoracic form of OPLL tends to involve upper thoracic segments predominantly, and is also not usually associated with cervical level involvement. Finally, I should mention on this study, you can see not only did this patient have OPLL, there was also dish anteriorly as seen in the lower thoracic levels with flowing anterior osteophyte. Now, I want to talk a little bit about diagnostic imaging. There is nothing particularly different about the radiographic evaluation of OPLL from other forms of myelopathy. Plain films, dynamic films, CT, and MRI all play a role. I should point out, though, that MRI by itself, which is often the first thing that spine surgeons are presented with, will not always allow you to make the diagnosis. You can see the cord compression to good advantage, but oftentimes the ossified nature of the ligamentous thickening is not evident. On CT, one can also visualize different patterns of OPLL, which have some degree of surgical implications. Four patterns typically referred to include the focal pattern as seen in the first panel on the left, where there is ossification across one motion segment in a fairly focal area. This is something that can be treated much differently than the more extensive patterns of involvement, such as shown in the continuous or mixed form, where multi-levels are involved. Here's a clinical example of a patient with the continuous OPLL, and as I said, you can see it quite well on the plain films, though it is obviously much better seen in the middle panels on the CT, and this gives you a better idea of the challenges that might be encountered if surgical intervention were considered. But also note on the right, on the MRI, the cord compression can be well seen, but the nature of the compression, whether it's ossified or not, is not at all evident on that study. So it is worthwhile remembering, especially when there is thickened tissue, as in this MRI, to consider CT to better understand what you're dealing with before embarking on a treatment plan. Dynamic films may play a role in OPLL. Much like congenital fusion or surgical fusion, OPLL causes a stiffening of several motion segments in many cases, and that produces adjacent segment changes that might be associated with focal dynamic instability. Flexion extension films help in evaluating that possibility and may cause a change in a surgical plan, either to include a fusion in the plan or to add a segment that may not be involved with the OPLL if dynamic instability has developed at that junction. Last comment I'll make about imaging relates to dural ossification. My co-author on this chapter has emphasized the importance of evaluating dural ossification in surgical planning. He has classified dural ossification in three types as shown here on this slide. Type 1 is an isolated focus of ossification that is not contiguous with any OPLL and generally does not require special consideration. The type 2 form, the double layer here, shows ossification in the dura that is adjacent to but not contiguous with the OPLL. And in this case, careful dissection could allow separation of the OPLL from the dura with a relatively low likelihood of a durotomy or subsequent leak. But the type 3, the en bloc or mass form, is such that one cannot separate the dura from the OPLL mass, and durotomy and CSF leak are a high likelihood in these patients and might result in consideration of an alternative surgical approach. Now I want to talk a bit about natural history. OPLL frequently will be diagnosed in patients incidentally, and it is important to know in those patients how likelihood are they to become symptomatic. A fairly large study was reported by Takatomi back in 1997 looking at the radiographic progression, and they found that in an approximately 5-year time span that the mass of ossification could increase as much as 24% in length and 13% in thickness. So this is certainly concerning and would justify close follow-up of these patients even when relatively mild symptoms are involved. But perhaps more importantly is the follow-up study published by Matsunaga and colleagues in 2004. This was a series of over 450 patients followed for an average of 17.6 years. In this study, they found that of the non-myelopathic patients, only 17% became myelopathic during follow-up. So prophylactic surgery in non-myelopathic patients with OPLL seems to be little justified. On the other hand, patients who presented with significant symptoms of myelopathy had a high risk of becoming wheelchair-bound, with 89% of them deteriorating to that state within the follow-up period, whereas patients operated on deteriorated to a wheelchair in only 17% of cases. So the take-home here should be that asymptomatic or very mildly symptomatic patients can be followed, but patients with severe symptoms will have a high likelihood of progression and will either need to be treated or closely followed. Now we'll talk about treatment of OPLL. Well, as previously mentioned, conservative treatment is certainly appropriate for some patients. Non-myelopathic patients may remain clinically stable for a long period, as was shown. So follow-up is an appropriate option for them, although it is important to consider a systematic approach so that one can detect progression reliably. Use of clinical scores such as the NURIC score or the JOA score or the modified JOA score may be appropriate. One may also want to look at dynamic factors on flexion extension films, which might predispose people to more rapid progression. As we noted earlier, neck pain and stiffness are common symptoms, and these can be managed symptomatically. But again, it's important to remember that not all asymptomatic patients are stable, and approximately 17% will progress. Surgical treatment is an important aspect of the management of OPLL, and it's important to remember that the primary indication is going to be progressive myelopathy. That being said, some patients present with radiculopathy, and this can occur either with concurrent myelopathy or independent of myelopathy, and these radicular complaints will need to be evaluated and addressed appropriately. It's also important to remember that multiple surgical approaches are available, and one needs to consider a number of factors that we'll get into in deciding on the appropriate surgical plan for the individual. As you know, there's a number of surgical options for the cervical spine. We'll divide them up into posterior and anterior approaches. From the posterior side, the most straightforward and familiar approach is the cervical laminectomy or laminectomy with fusion. Laminoplasty was largely developed in response to the difficulties presented with OPLL, and a number of different techniques have been described and advocated to achieve a laminoplasty approach. A survey of the Australasian spine surgeons recently showed that the open door laminoplasty is the most common approach used by far and is perhaps the simplest approach from a technical standpoint. But other techniques have been described and have their role. More recently, a standalone fusion approach to OPLL has also been described, and in a small series seemed to show satisfactory results, which admittedly is somewhat counterintuitive. Now, posterior approaches in general have a number of advantages. First of all, it's a familiar approach to most spine surgeons and is relatively easily extended up or down as needed. It avoids many of the complications of dysphagia, dysphonia associated with anterior approaches and can be done with or without a fusion. It also appears to have a lower rate of CSF leak, and when a durotomy is incurred, is more straightforward to repair in most circumstances. So there are definitely advantages to posterior approaches. However, there are also a number of disadvantages. The most significant one in the case of OPLL is that the compression is largely anterior. So you're indirectly decompressing the cord, and in patients with some degree of kyphosis, this cord compression may be inadequate. Secondly, laminectomy approaches and to some extent laminoplasty approaches increase the risk of postoperative kyphosis, and they have been shown to be associated with a somewhat higher rate of C5 palsy, though C5 palsy can occur with either anterior or posterior spine surgery. Additionally, posterior approaches may be associated with recurrent compression, both at the limits of the previous decompression or because of progression in the OPLL itself. This is thought to be more likely to occur in patients who do not have a fusion. And finally, when patients who have severe cord compression and anterior and posterior approaches have been compared, the anterior approaches seem to do better with high-grade compression. Laminoplasty specifically has become much more popular with the advent of numerous implants, as shown on this slide. There's a variety of commercially made devices for performing laminoplasty, most of which are directed at the open door technique, though some ceramic implants can be used with the French door or Z-plasty type of laminoplasty techniques. And this has made it much easier to construct a durable construct than the earliest techniques. Alternatively to the posterior approach is the anterior type of approach, which can range from a simple ACDF to single or multi-level corpectomy, and a newer methodology has been described, variably titled anterior controlled anti-displacement infusion, or some other terms are applied, which is an osteotomy technique to translocate the ossified mass forward. And we'll show a diagram of this in a few minutes. The advantages of the anterior approach, I think, are obvious. First is that you can, in appropriate cases, directly remove the compressive mass, and you can also easily eliminate any dynamic component through anterior fusion, which has a high rate of success. Also, in some circumstances, you have the ability to correct kyphosis, and as I mentioned earlier, with severe compression, the neurologic results with anterior surgery are superior, though with lesser degrees of involvement, the two approaches may be more equivalent. But, of course, the anterior approaches have their disadvantages as well. The most significant and most common are the incidence of dysphagia and dysphonia, which can be debilitating and require placement of gastrostomy tubes and the like, and change one's lifestyle significantly. CSF leak is also perhaps more common and is certainly more difficult to manage with anterior surgery. And this is especially true when there is a large ventral mass extending over several segments and there is concomitant dural ossification. Also, with corpectomy procedures, subsidence and graft displacement can complicate an otherwise good result, and the necessity of fusing most anterior approaches results in a loss of range of motion, which may be undesirable in some cases for patients. This is the anterior controlled anti-displacement approach. It involves creating osteotomies on each side of the central vertebral corpus, and then using a long anterior plate spanning the level of OPLL to pull the vertebral bodies forward with the screws in what the authors have described as the bridge crane technique. This was developed mainly for the continuous form of OPLL and a higher risk of durotomy. As you can imagine, it has some real technical challenges, but has been shown in a few publications to have relatively encouraging preliminary results with an acceptable number of complications. Aside from the usual anatomical variables that we've been talking about, some other considerations may assist the surgeon in deciding on the optimal surgical approach. One such consideration is the canal occupying ratio illustrated on this slide. It's also described in the literature as the space available for the cord. Canal occupying ratio, as diagrammed here, is the ratio of the OPLL to the overall AP diameter of the canal and is expressed as a percent. It's been shown that canal occupying ratios of greater than 50% favor the anterior approach. Results are better when an anterior approach is used for high-grade anterior compression. More recently, the T1 slope has been advocated as a way of assessing cervical lordosis, and some authors have looked at this in decision-making for OPLL. It's noteworthy that patients with a higher T1 slope preoperatively will have a greater degree of lordosis in general, and when operated on will have a greater loss of lordosis when laminoplasty is performed than people with a lower T1 slope. But this is not that surprising, and in fact, although they lose more degrees of lordosis, they do not appear any more likely to drift into frank kyphosis. So at this point, I think it's unclear whether this is a valuable consideration. On the other hand, the K-line, as illustrated on this slide, may be a useful tool in deciding between anterior and posterior approaches. The K-line, as diagrammed on the left panel, is a line drawn between the midpoint of the canal at C2 and the midpoint of the canal at C7. And this line then can be evaluated in relation to the bony mass. The panel on the right shows a patient with a K-line that passes posterior to the bony mass, and that's termed K-line positive. And on the far right, the K-line passes through the bony mass, and that is termed K-line negative. It has been shown that anterior approaches tend to provide superior results for patients who have a K-line negative configuration. And again, this is not surprising. This is what we see when there is greater kyphosis. Posterior decompression does less well. Now, I do want to just touch on some of the complications of OPLL treatment. They are not particularly surprising and not grossly different from managing cervical spondylotic myelopathy. The one thing that may be somewhat more problematic with OPLL is durotomy, especially with anterior approaches, and this can be difficult to manage when an anterior approach is utilized. Neurologic deficit, C5 palsy, these are things that occur with both approaches, some authors have suggested that C5 palsy is more likely with a posterior approach, though it can be seen in anterior surgery as well. Graft complications are more often associated with anterior procedures. Implant complications likewise, though with increasing use of lateral mass and pedicle screws posteriorly, as well as laminoplasty plates, these complications have become more prevalent with posterior surgery as well. Hematoma obviously can occur with both approaches, but is more significant in terms of risk in the anterior cases due to compromise of the airway. And of course, dysphonia, dysphagia, and dysarthria are all associated with anterior surgery. On this table, I've attempted to break down various preoperative factors and assign a relative score as to whether they would point you to a anterior or posterior approach. And as you can see in the first line, asymptomatic patients generally recommended for observation. If surgery is contemplated, laminoplasty may be associated with less morbidity. Segmental OPLL involving 2 or 3 vertebral levels is very well managed with an anterior corpectomy kind of approach, whereas continuous OPLL involving multi-segments may be associated with lesser morbidity in general via a posterior operation. But other factors such as K-line may also play a role in decision making, whereas a K-line negative patient, even with continuous OPLL, might be best treated with anterior surgery. High ratios for canal occupation likewise point you in an anterior direction, whereas high level of dural ossification might be better treated either with a laminoplasty or posterior approach in general, or perhaps with the newer anterior osteotomy techniques. Dynamic instability should perhaps lead one to incorporating fusion, and patients who are smokers with a high risk of non-union may be better treated with a laminoplasty without expected fusion than with some of the anterior approaches where non-union could be an issue. In conclusion, OPLL is a less common cause of cervical myelopathy than more typical spondylotic myelopathy, yet it is important because it presents the surgeon with different considerations as to the most appropriate management. Because of the predominant ventral compressive pathology, the decision-making algorithm can be somewhat different and requires different analysis and decision-making for optimal outcomes. Patient individualization is critical to achieve the best results. Thank you for your attention.